said, we're much more cautious about vaccinating children because the ethics of vaccinating children to protect adults is quite complicated. And we're going to have that discussion at some point as a society, but it's not the same as measles, where you vaccinate children to protect children, and then they're protected for life. And then you can end up in the situation where you have almost complete population immunity. But even with measles, with this incredibly effective vaccine, and where you can actually, you can get to these very, very high levels, including down in children. People have talked about eliminating measles for a very long time, and countries come in and out of elimination, but it hasn't been achieved yet for any significant period of time, and that's the real risk. If by elimination you mean 0 cases transmitted in a clear and reasonably large geographical area, which is how I would define it, we are nowhere near eradication on measles, for example. So I think, people, that comparison, whilst I understand the points being made, I think is quite a difficult one to sustain. The general principle that we should try and get the rates absolutely as low as possible, completely agree. And, if I could choose to magic this disease away, I think there's sometimes an implication that somehow people who argue you can't have 0 cases want COVID to continue. I would love COVID magically to disappear, but I'm an infectious disease epidemiologist. This is something I've thought about quite a lot over many infections. Getting rid of infectious diseases that have a significant asymptomatic spread, highly transmissible across all ages, respiratory transmission all around the world, that's quite a tall order. So I think it is very important to, if we get to the point where it is at such low levels, we finally can say, oh, we're very, very close to elimination, let's give it a go, fine. But we are an incredibly long way away from that one now. At this point, we should be concentrating all our efforts on getting it down as low as we possibly can, and then see where we go. And all of us want to get to the point where there is as low cases as possible. And if we can get to 0, fine. But I think that the very, very few scientists who have looked at this actually think getting to 0 is a realistic option. All of us think getting to very low rates is a realistic option, and that's what we should be aiming for.
Okay, so at the lowest level of our current COVID alert system can only be reached when there's no cases in the UK. So do we need to be revising this if a 0 COVID approach is not possible?
Well, I think when we get down to the point where we're at the next lowest level, where there's very, very low levels and we're not getting significant importation, and we will get potentially to that point with vaccination in the UK and globally. And it is very important we see this as everyone's problem globally as well as just a UK problem. We can't just solve the problem here and then have done with it. Then I think that debate is a very right one to have, but we are quite a long way away from there now in all 4 nations and across Europe. So I think we should be humble in the face of a very, very dangerous and highly prevalent virus at this point.
Okay, thank you. I suppose that is something that us as a committee and the government will need to come back to then at another date. And Sir Patrick, if I could just direct my final question to you. The government has talked about reopening of international travel from the 17th of May. Are you comfortable with that? Was that a recommendation of yours?
Well, again, we don't make recommendations on specific actions like that. And what we've given advice on is the relative measures, the relative importance of different approaches to border controls. We've published that evidence, and we've given a very clear recommendation that the keeping levels low in this country is what we should really be aiming for as a priority. But we don't give advice on specific actions.
And are you expecting, are you happy with that particular piece of government advice, though?
Well, I think travel will reopen as inevitably at some point travel will reopen, and clearly as more countries become vaccinated, and it reiterates the point that the fighting of this virus is a global thing. It's not a national thing, it's a global thing, and therefore vaccines need to get out to other countries as well. As more countries become vaccinated, and as we get the ability to understand how much transmission reduction is reduced by vaccination, it makes a freer movement across countries much more possible again. And that's clearly what needs to happen at some point. Whether or not that's with certification or whatever, we'll see. But I think at some point travel has to reopen, and it has to be done in a way that's safe and can be detected in terms of variants and so on, which speaks to a screening program which has to be global.
Thank you. I think you're maybe avoiding the subject slightly. We know that other countries are way behind us in terms of vaccination. So really it's about this date, which is in about 2 months' time of the 17th of May, and whether that's a sensible date or not.
Well, I will answer again. I've been very clear that we are going to have to measure as we go along, and we don't know. So I'm not.
Thank you, Sir Patrick.
The dates are really only times when we look at data.
Thank you, Sir Patrick, and thank you, Professor Whitty.
Thank you, Carol. Dawn Butler, then Catherine Fletcher.
Thank you very much, Chair. Professor Whitty, I mean, I understand that a zero COVID strategy isn't about zero COVID. It's about the approach taken and how the government acts to try and eliminate as much as possible the risk of COVID. So, for instance, having unclear messaging isn't a zero COVID strategy. A zero COVID strategy would mean you'd have the clearest messaging possible so that people follow all the instructions and directions, so they're compelled to do that. Like if we educate people in regards to being outside as opposed to being inside, mitigating the risk that we spoke about earlier. That is a zero COVID strategy. So the strategy is different from saying we want zero COVID. Is that not correct?
Well, I have to admit that as a scientist, for me, zero means zero. So if you're saying I want a zero COVID strategy, what you're saying is I want zero COVID cases. Now, you can say that. What I'm just saying is I don't think that's a realistic option. Now, if people say, well, by zero, I don't mean zero, I mean another number, fine, but then put a different number on it. I completely agree with your thesis, though, which is clear messaging, trying to be simple, trying to actually make the points as explicit as possible, and to go back to our previous discussion, trying to make sure that every community is reached by messaging in an appropriate way. Those are absolutely central. So I think, in a sense, I'm not disagreeing with you, except I'm just making a very specific point about the term zero, which has a meaning in science, and I think we should stick to that meaning.
Fair point. I mean, I didn't create the meaning, but fair point. The other question I have is on test and trace. Do you think that the resources spent on test and trace should be spent on other interventions? Would it have a better outcome?
Well, I think resource questions I always avoid answering just on a matter of principle, because that's really a question for ministers. But I will say a bit generally about the benefit of test and trace, fully accepting there are multiple other things we have to do. It has to be seen as part of a wide sweep of different things. And within test and trace, there are kind of at least 3 different elements which have different purposes and different advantages. One of them, which is the one that I interact with on a daily basis very closely, is the information gathering bit. The Joint Biosecurity Centre, and the UK now has an incredibly sophisticated system across all 4 nations for gathering data, some of its ONS data, some of its test and trace data, so that we actually know where we're going. And this goes back to the initial premise of this whole discussion, which is that is the data which will help us decide, is it safe to move forward to the next stages? So all the data that's collected in very considerable detail by a variety of different routes, which you can then triangulate, is really critical to making safe and sensible policy decisions. Then there's a very important part of the testing and tracing system, which is around testing people who are symptomatic and might have this, so that they isolate if they've actually got COVID. And that is really critical, and there's really clear evidence that's a very, very important part of it. But it also means that people who don't have COVID can go about their daily business once they've been cleared from that point of view. And then the final bit is the case finding and contact isolation. And that's also an important part of it, and will become an increasingly large part as we get down to much lower numbers. So I've said right from the beginning, because it is a kind of basic principle of public health, epidemiology management, that case finding and isolation and contact isolation has a much smaller part to play when you've got incredibly high numbers, simply for practical reasons as much as anything else. As we get down the numbers curve, an increasingly high proportion of the heavy lifting can be taken by that. So our hope is that simple interventions like washing hands, face masks where it's appropriate, test and trace, and above all vaccines together will provide a lot of the really heavy lifting for keeping the virus rate down for much of the remainder of the year once we got it down from this initial lockdown. So I think
Yeah.
you know, we could see the different components in different ways.
Yeah, I mean, I agree. But for people to self-isolate, that comes with its own complications in regards to can they afford to, etc. But my last question to both of you, please, is there's obviously a gap in regards to the science and then what the politicians say. What has been your biggest frustration? Professor Whitty, do you want to say?
If I'm perfectly honest, and this is not aimed at politicians either in government or not in government, is a general statement, it's when what we think we have said, or I certainly think I've said clearly, is then misrepresented to the general public. And the reason is that that causes confusion. It's back to your previous point. It's absolutely critical that we give clear messaging. Now, sometimes I give unclear messaging. It's my fault that I'm just not communicating clearly. But obviously, you also have situations where people misrepresent what you're saying for whatever reason, and that confuses the general public. And that really is not helping in a general pandemic. So my frustration is actually when science advice given publicly is in a sense miscommunicated. But I, absolutely would take my own share of the blame for that, because sometimes that is because I simply haven't communicated well enough myself. So I'm not trying to point fingers at other people.
I hear that. Is there an example you could give us?
I'm not going to give examples because that would be unfair. I'm just making the general point.
Fair enough. And Sir Patrick.
Well, Chris has said exactly what I would say there, and I'm also not going to give an example because that's the example that would then become exactly used as described. So I shan't do it. But the other sort of frustration in the whole thing, which I think it is not to do with politicians, or it's to do with we've at every stage have to deal with imperfect information. There's uncertainty, and what we're trying to do is to express what we know and what we don't know and what the uncertainties are around that. And that's going to continue to be the case. And I think that uncertainty is what we all need to bear in mind. And it doesn't mean that the science isn't valuable. It's incredibly valuable because it bounds around that uncertainty, but it's not a precise answer. It is a best information at the moment.
Thank you.
Thank you both very much. Thank you, Chair.
Thank you very much, Adido. Just to follow up Dawn's questions on test and trace, Pastor Patrick, SAGE in the autumn thought that the test and trace system was not making a significant contribution to reducing the R rate. Is it now?
Well, test and trace, I think, is working very well at the moment, and testing is obviously, as Chris said, incredibly important for the information we have to monitor this. So I think there's a very good testing system in place now, which reaches a high proportion of people who are positive, and that's going to be increasingly important as we come to very low levels. And the reason, and again, this is something that is worth just being clear, what was said when SAGE made a comment about test, trace and isolate, it was that at very high prevalence levels, contact tracing and isolation becomes progressively less important because the disease is everywhere and you can't do it. So what becomes important then is obviously isolation and taking people out of being able to circulate. As prevalence comes down, test, trace and isolate, and it's worth remembering the isolate bit remains very important, becomes increasingly important to try and stop the cases that are there from being able to spread it. So I would anticipate the impact of test, trace and isolation is actually going to become even more important over these next few months as we go into hopefully lower levels and ability to then get back to a form of normality.
The testing system, what about the tracing system? What's your assessment of that at the moment?
Well, I think that the examples that we've seen recently of the tracing system being able to identify cases of new variants and track them down even when forms have been lost is impressive. And I think, you know, we've got a much stronger system than we had, you know, certainly at the beginning. And it's taken a long time, of course, to get it there because it's a complicated thing to do. But I think it's working pretty well. And I think that tracing is going to be important, particularly so-called backward contact tracing, when you ask the question, where might this person have got it from, and can I trace where they have got it, so you can identify clusters. And that's what's going to be important, I suspect, as we go forward.
The roadmap in terms of unlocking, as we've discussed extensively this morning, depends on a number of assessments on the effectiveness of the vaccine, its rollout, the spread of transmission. How important has test and trace been in your advice to government as to the pace of unlocking?
Well, what the modelling has assumed is that there are baseline measures which will be effective as things are unlocked. And one of those is test, trace and isolate. Others include things like hand hygiene, include things like mask wearing and so on up to a certain point. And so those baseline measures are assumed to take some of the lifting going forward as we unlock.
The Test, Trace and Isolate organisation has made an estimate of its impact on R, which I think from memory extends to up to 0.8. Have you assessed their assessment?
Well, we've done various assessments over the course of the last 8 months or so of impact of isolation, testing, tracing. I don't have all the figures at the top of my head, but we've published several things on that over the period. We haven't looked specifically at the work that they've done, but and I think the impact of test, trace and isolate does vary depending on the state of the epidemic. As I say, at very high prevalence, it's very difficult for that to make a big impact.
But in terms of the assessment that they presented to this committee and to the Public Accounts Committee, and was part of their business case for quite considerable sums of public money, over 25 billion that they're spending, SAGE and its subgroups haven't validated that, or am I wrong?
We haven't been asked as SAGE, and it would be a slightly strange thing for us to be asked to do, to validate that for that purpose. I don't know. I suspect they have been involved, but I don't know which of the modelling groups may have been involved in helping that. They're quite closely linked in to JBC and other parts of test, trace and isolate, so I wouldn't be at all surprised if some of the modelling groups have been involved in that.
A final member to ask questions before we have some brief supplementaries is Catherine Fletcher.
Thank you, Chair. Gentlemen, thanks hugely. Always a pleasure. And to be schooled and to learn from your munificence. Now, my dad's a fan of yours, and he for many years has participated in the UK Biobank study, longitudinal study, based in a wonderful facility in South Manchester in Cheadle. And he recently got a lateral flow antibody test through the post, which I assisted in drawing his blood in at the weekend, and happy to confirm that his first dose AstraZeneca vaccination has produced not only a strong IgM response, but also a strong IgG response. Now, many moons ago, back last year, antibody testing, so for the uninitiated, have you had it and are you immune, versus the antigen testing of have you got it now, was, that antibody testing was hailed as one of the ways that we recover and return to normal life from the pandemic. Given that we're now testing lateral flow antibody tests, perhaps, Sir Patrick, you can talk about what role they've got to play moving forward.
Yes, so first of all, I should declare that I was on the board of Biobank for a number of years, and so I know that organisation well, and I'm strongly supportive of the work that they're doing, actually, which I think is going to be important. You're quite right that the antibody levels are now increasing across the population, particularly, of course, in the above 60-year-olds who've been vaccinated. And I was just looking at some data this morning, and we're getting to quite decent levels of antibody there, and that speaks to the question of, you know, what do you do about using that for some form of certification and so on. And I think the Royal Society has produced a very good document on that with 12 things that need to be considered when one thinks about certification, ranging from what are you trying to use it for, because clearly what vaccination or an antibody positive test tells you is that you may be protected personally. It doesn't tell you that you can't spread it to somebody else. That's different from an antigen test, which might tell you you don't have it today and therefore you might not spread it today, but you might of course catch it tomorrow. So there are different tests. You need to think about how durable those results are. You need to think about how they can be protected for you as the individual, how verifiable they are. And I thought the 12 tests that the Royal Society laid out were a good way of thinking about this as governments think about how they want to consider any form of certification around this, including issues around equity and inequalities that might arise as part of that. And we, you know, had a lot on that today, rightly, because, you know, this is a disease which feeds off inequality and feeds inequality, and we need to watch out for that as we go to any new measures. But I think it's likely that we'll have some form of international agreement around how to use these things for travel.
Almost test to travel coming through a post box to you soon. No, thank you. It's an exciting development, and he was genuinely excited. I think maybe slightly more broadly, just to close. You know, I have an aunt and uncle also in South Manchester who have been giving blood on a regular basis to the Oxford studies, and there is a huge groundswell of not only interest in but value of and understanding of what we can do as the British public to participate in scientific research. So, you know, whilst we're still locked down and we're still just looking at that light at the end of the tunnel that's coming, what would you say to the British public about participating in the life sciences, whatever you are and wherever you are? Perhaps Sir Patrick and then Professor Whitty?
Yeah. I mean, first of all, I'd say a big thank you, because it's been fantastic. And actually the response of people to the scientific studies has been really spectacular. If you take something like the recovery study, it was over, I think it was over 11 or 12% of people, possibly even higher, who were in hospital were part of that study. That is fantastic and exactly what we should be aiming for. When we don't know the answer, as we didn't for those drug studies, and indeed for many forms of research by definition, making sure that we can encourage people to get into trials is the way to get answers. And we've seen that really dramatically across this. I mean, the UK has been brilliant in the studies that have been done that have come up with answers, what works, and as importantly, what doesn't work. So we don't end up giving things to people that don't work. So I'm absolutely excited about the fact that the British public has been so great at taking part in these studies, and they're so interested in doing so. And I hope that will be one of our lasting legacies from this, that we will be a country that continues to really have widespread public participation in science, and that we have a system for getting answers to those questions that we don't know as a result.
I'm just going to, in a sense, echo to some extent what Patrick said. I completely agree. Massive thanks to all those who've been involved, not just in trials, but also in the observational studies, which have been very important to our understanding. And I mean, just three additional points, one of which is to say thank you to your family, who are clearly A, part of the scientific effort, but B, actually very typical.
Very far from the getting enthusiastic about studies tree, unfortunately.
Yeah. But we're getting very close. I mean, one of my other roles is I run something called the National Institute for Health Research, which actually does a lot of is the structure for a lot of the clinical research. We're getting very close to the point where almost 1 million people in the UK have taken part in clinical studies, either observational or trials, and that includes trials of drugs, where the UK has really taken a leading role, trials of vaccines, where we've obviously the AZ is the exemplar, but also we've trialed drugs as well, but also the big observational studies, the SAREN study in healthcare workers, the COSIN study, which has actually looked at a lot of people who got severe disease, and in fact, going back to some of the earlier discussion, really helped to tease out some of these issues around risks for people of different ethnic groups. So the extraordinary volunteer spirit that people have shown, the patients in hospitals, the volunteers of trials, and also doctors, nurses, other healthcare workers who, on top of their day jobs, have enrolled people into studies, made sure it's safe for them to do it, done all of the work. because that's the way that we've actually managed to really accelerate the knowledge in this disease. And the UK has done more than probably almost any other country per head of population because of that volunteer spirit from the population and the healthcare staff. And my final point is, if you look around the UK, all 4 nations, it's not just the teaching hospitals. We're talking about the district general hospitals, the general practices, healthcare workers in more community settings, people working in nursing and residential homes. So this is across all of society that this is being taken part, and it's a real gift to the future. That's the way we're going to get on top of this virus, and indeed it's an offering in a sense from the UK to the whole of the world. So it's basically a very long-winded way of saying thank you.
Thank you, Catherine. Just some brief supplementaries. One from Graham Stringer.
Brief, well, I hope the brief supplementaries. We're coming up to, in fact, we've probably passed it for a number of people, the 12 weeks since the first vaccinations. When the commitment to give those people a second vaccination comes around, will that lead to a significant drop in first vaccinations, and do you have numbers for that? Sorry, Professor Whitty.
Well, I think that so the first thing is that because we did the delayed second dose, we've been able to vaccinate a much larger percentage of the population. And as Patrick has said, I think that has proved to be a sensible decision. It was obviously a decision based on data, but it was indirect data, and I think now in retrospect the data are backing up that that was a reasonable, safe and sensible decision, because it's led to a much larger proportion. Now we are revaccinating people, and that has now started, but it'll really start to take off, because if you think back, 12 weeks ago was back in December, and that was the point when the vaccination program was really beginning to take off. So of course this is going to follow. So we're going to start seeing the numbers of people getting their second vaccines really starting to move up quite rapidly now. And the most recent data on that show over 1 million people have had a second vaccine now, but we're expecting the numbers significantly to go up. Now, of course, the problem we've always had, and this is the reason we delayed the second dose, is limitation on supply. But at this point in time, our expectation is we'll be able to manage that second vaccination, which is really critical people do it. And I really want to stress to people, if you've got family members who are thinking about doing it, really encourage them to do it, because that's how you get full and long-lived protection. The bigger bit is from the first one, but you still get significant additional protection from the second vaccine, and probably more long-lived protection. So really critical people have that. But there should be enough vaccine supply additionally to roll out the first vaccine to the larger part of the population, who still haven't had one vaccine. Of course, there's a large numbers of caveats to that, because vaccine supply is always subject to all the problems of any kind of drug supply. But at this point in time, our expectation is we can both, over the next few weeks, continue to do the second vaccination, but additionally do first vaccinations as well. Of course, it won't go quite the same rate as if you were only doing one vaccination, but we do expect to be able to do both.
Thank you. Surge testing, we've not really touched on it, but I looked on the website this morning. It said the objective of surge testing was to better understand the virus and to monitor and suppress the spread of the coronavirus. I think looking on the website, there were 28 surge testing projects, there may be more by now. Have those objectives been met, and are there any other objectives? Has it been an effective programme? Professor Whitty, sorry.
Well, I think with all of the various forms of testing, the first thing to say is that you're not taking someone from a high risk to zero risk. What you're aiming to do is to reduce risk by identifying people who have got infections, who don't know they got infections in these surge testing models, and then making sure that they can then isolate, knowing that they've got the virus. The assessments of them in places like Liverpool have, in a sense, been mixed in both positive and negative ways. The positive assessments, and I think it's well worth looking at this, and the colleagues in Liverpool have really been very good at assessing this and designing it in a very good way, the University of Liverpool and others. Positively, significant numbers of people have been identified who otherwise would not have been identified. The downside on this is that, as always, there's what's called the inverse pair law, which is where there's less ability to do this with strong support in areas of higher deprivation, where in fact the risks are, as we were discussing earlier in the session, potentially greater. So this is not a panacea at all, but it is a useful addition to other measures, provided it's properly targeted, and when we're doing it in a new way, provided it's properly assessed. And of course, there are different sorts of surge testing. So additionally, there's the surge testing, for example, that's done around variants of concern, and that's for a slightly different reason. That's to pick up or identify the size of the problem, and to make sure that we can reduce the risks that things like the South African variant are widely spread. So there are a variety of reasons for doing it, the variety of mechanisms. None of them are perfect, but our expectation is that most of them, certainly some of them, probably most of them, have had a significant, useful, additional effect on top of other activities, but they're not a panacea.
Last one to Professor Vallance. You were both extraordinarily helpful at the start of this epidemic in opening up both the membership and the minutes of SAGE, so that we could all understand what was going on and who was involved in the process. Unfortunately, NHS England haven't been as open with the information that might enable us to understand what's going on. Local NHS trusts are really controlled and can't put out information without the say-so from the centre, which often doesn't come. Trying to get the number of cancelled elective operations, trying to get the number of cancelled emergency operations is very difficult. And we also now have the Biosecurity Centre, which isn't as open as SAGE. It's a request to both of you, but I'd like Professor Vallance to answer. Openness in this epidemic is vital. I think you agree on that. Can you put pressure on all the bodies, NHS England, Biosecurity Centre, to put out as much information as they have?
I'm in favour of making sure that as much information as possible is made public, and I've made that point repeatedly and will continue to do so. And
will you put pressure on to do that? That's your view. You both have very influential positions to put pressure on these organisations.
Well, I certainly do ask for the areas that are relevant to what we're doing, that we make data available as we can. I clearly can't be responsible across the whole of the other parts of government for this, but I think, yes, we ask for that, and I will continue to ask for it and continue to make the point that I think openness is the right way to deal with this, and it allows other people to look at the data, analyse it, draw interpretations. It's a very important part of the scientific process.
Thank you, Graham. And just to reinforce what Graham said to Sir Patrick, you've been absolutely instrumental in changing the procedures of SAGE to make the papers open from the outset. And that was a personal initiative at the request of the committee, and we're very grateful for that. It's been very important to the scrutiny and learning from the pandemic. Finally, Aaron Bell.
Thank you, Chair, and thank you again, gentlemen. As a computer programmer, I always found that treating 0 as a number equal to 0 was pretty useful as well to avoid any unexpected behaviours. So I think we're as one on that. But the roadmap said that all limits on social contact will be removed eventually. Which restrictions, if any, would be needed after the 21st of June date? Sir Patrick first.
Well, I don't know, because as I think, tried to say that we need to look at what we measure every 5 weeks and see where we are. So it rather depends on where we are in the epidemic. I'll answer sort of slightly more helpfully though by saying that I think that next winter, I wouldn't be surprised if we have to keep some sorts of things in place as numbers go up again. I certainly think we should keep the hand hygiene going. I certainly think we should keep test and trace in position so that we can monitor what's going on. And I think it's possible that there'll be situations where masks need to be worn in certain crowded situations if numbers go up next winter, but it's very dependent on data and how this goes.
But no social distancing, just masks.
Well, it's possible that there's some form of, I think two things. First of all, I think there will be some innate social distancing just because of behavioural change. People will actually behave slightly differently, which will create some of that. And we don't know how much more may be needed over the course of next winter. Next winter won't look like this winter, but it won't, there will still be cases, there will be increase in numbers, I suspect, and we should expect there to be some sort of pressure next winter, but nothing like we've seen over the course of this winter would be my view.
And if we come to masks, would you envisage that would be something that's largely voluntary and encouraged rather than compulsory next winter? Because it seems to me that we will be in a very different place, and it's much like it is how, it's up to people whether they go out and risk catching the flu. Are we not in an analogous situation potentially next winter with COVID?
Well, if we're in that position, if vaccines are as effective as they look as though they are, and we've got great coverage and this is controllable, clearly you don't need as many things to be there, and you could release many of them. If that's not the situation, and something has happened, new variants, whatever it might be that changes it, then we'll have to see where we are and respond accordingly. So I think it's just too early to say how this will look.
Thank you. And on that point, the Prime Minister has obviously indicated that the point of this roadmap is to do things irreversibly. Under what circumstances could you envisage measures being reintroduced? Is it simply the variant situation, or are there any other reasons you might think we do need to reintroduce measures in the United Kingdom?
Well, the aim of measuring as you go along is to make sure that you take the right steps when you've got the information. I don't think we yet know how this is going to play out longer term, but I think, and Chris may want to comment, but I think our view is that this becomes progressively less of a problem as we go forward. It doesn't mean it's going to be zero problem over next winter. I think there will be cases, and so reintroduction of measures is entirely dependent upon the course of the pandemic and things like if there's a new variant that completely escapes immunity, which I think is unlikely. I think more likely the vaccines will have an effect. They already do have an effect on most of the variants. The higher the immune response, the better it covers some of the other variants as well. Variant vaccines are being produced, which will have an effect. So I think it's all pointed in the right direction, but I think nobody can say with certainty that this is finished, and we're certainly not out of the woods yet, even on this wave.
Thank you, Sir Patrick. Professor Whitty?
I start with a very healthy regard for the pragmatism of the people of the United Kingdom, all four nations. People know that winter is when seasonal viruses tend to be worse, and our expectation is there'll be surges in winter. People know this is a new virus about which we do not know full amounts. I don't think anybody's expecting us to be able to predict exactly what we needed, when, where, and how. I think we'll take it as it comes. None of us want to have unnecessary measures at all. Equally, none of us want just to not have measures just on a point of principle when it's obvious we need them. So I think the sensible thing is we just take it as it comes.
Thank you both very much. It's been very helpful.
And doesn't it follow from that, Professor Whitty, that the right demeanour is actually to be ready, to be poised to take measures if they're necessary? And actually, is this whole doctrine of irreversibility in one way actually not the right stance that we should be taking? Shouldn't we be preparing ourselves to be poised to spring to take action, perhaps in the winter if necessary?
Well, I mean, I absolutely not want to speak for the Prime Minister, but I think what he means by irreversibility, and I think what most people understand it to mean, is that in the foreseeable future, we don't go down a path which we have a very high chance of having to reverse almost immediately out of again. I don't think anybody is trying to say, well, we have absolute certainty about exactly where we'll be over the entirety of the next 5 years. I don't think anyone in the country is expecting that, and I certainly am not. I doubt any of the committee are. So I think irreversibility is to do with what we can see in the next period. There are some uncertainties ahead, and we'll just have to deal with them as they come.
Thank you. We've talked a lot about dates and putting forward some of the questions that will arise in the debate around this in the Chamber of the House of Commons as to the timetable. And you've set out why these 5-week intervals are appropriate. Perhaps just coming at it from the other side, how would you assess the risk of not being able to make the best before dates, as it were?
Well, by definition, I don't know, which is why we want to measure. Currently, things are looking good. They're headed in the right direction. Numbers are coming down quite well. Very pleased to see death rates coming down steeply. So it's all headed in the right direction. And if that continues, then that's a very good path to be able to do what's in the roadmap. Clearly, if there's some unexpected upswing, and Chris has already alluded to the fact that there's an increase in numbers being seen in some countries in Europe, which, if you were to take a historical view over the past year, we've tended to follow that when it happens. Hopefully it won't happen this time because of vaccines, but we need to be vigilant.
Thank you. So do you regard is your central expectation that the dates that are published in the roadmap will be the dates that the various unlockings will happen?
Well, my expectation is that the dates in the roadmap are the dates at which we will have data that we will feed into ministers to make decisions.
Thank you very much indeed. You've been very generous with your time and your expertise and experience. As I said at the beginning, this is a session in which we've tried to put some of the questions that we know are on the minds of other members of Parliament. There are 11 of us on this committee, the 650 members of Parliament. They will be debated in the chamber of the House of Commons when these measures come for approval and the debate around that approval. So you've done us a great service by answering a lot of the questions that are on people's minds, and for that and for your great efforts throughout this pandemic, we're very grateful. That concludes this meeting of the committee. Order, order.
Thank you very much.
Committee, 9th of March 2021.